Welcome to the IDEX Continuing Education Series.
Welcome to the SDMA and IRIS Chronic Kidney Disease Guidelines Update. The focus of this session is to look at the International Renal Interest Society, or IRIS, Chronic Kidney Disease, or CKD Guidelines, with a particular emphasis on the changes that were made in late September 2019. Prior to getting into the IRIS CKD guidelines themselves, we're quickly going to recap on what exactly is SDMA and how do you interpret an elevated SDMA. The key point to remember is that increased SDMA does not necessarily mean chronic kidney disease. We need to make sure we are doing a complete investigation when SDMA is increased so that we don't lose sight of the aspect of SDMA that is not CKD related prior to assigning a patient as having CKD. So what is SDMA? Well, SDMA stands for Symmetric dimethylarginine. But what does that really mean? It is a methylated form of arginine that is present in the intracellular proteins of all nucleated cells. We have a fairly stable rate of nucleated cell turnover on a daily basis. So when these nucleated cells are broken down, the proteins inside them are broken down, and SDMA is released into circulation. SDMA is primarily eliminated via renal excretion. It is not bound to protein in plasma, it is freely filtered by the glomerulus, and it is not secreted or reabsorbed by the tubules. Therefore, it is an excellent marker of glomerular filtration rate, or GFR. GFR is the gold standard for measuring kidney function. As a biomarker for GFR, anything that makes our patient's GFR decrease will cause SDMA to increase. Thus, we can see increases in SDMA with pre-renal, renal, and post-renal disease. Let's talk through three key attributes of SDMA. Three key attributes of SDMA that make it a more reliable indicator of kidney function than creatinine are: 1, it is a reliable biomarker of kidney function, as it is almost exclusively excreted by the kidneys, approximately 95 to 96%. Many studies have shown that SDMA is a good biomarker for kidney function in both dogs and cats, and that it correlates extremely well with gold standard GFR measurements. SDMA increases earlier than creatinine. On average, the blood concentration of SDMA increases above the reference range when our patient has lost 40% of kidney function, or as little as 25% loss of kidney function, particularly in cats. This is in contrast to creatinine, which doesn't increase above the reference range until there's been a 75% loss of kidney function. With regards to chronic kidney disease, this translates to SDMA increasing on average 17 months earlier in cats and 9 months earlier in than creatinine. Thirdly, SDMA is specific for kidney function. It is not impacted by external or extrarenal factors such as diet or liver function. In addition, it is not impacted by lean body mass. So what do we do when we have a patient that has an elevated SDMA? We have this algorithm that we can follow to determine whether acute, active, or chronic injury is occurring and how to begin to investigate, manage, and monitor the disease. It is for use when SDMA is increased, irrespective of whether creatinine is normal. Please note, in puppies, the reference range for SDMA is 0 to 16, whilst in adult dogs, cats, and kittens, it's 0 to 14. For any elevation in SDMA, we recommend performing a complete urinalysis to start your investigation. Remember that a complete urinalysis has 3 components: exam, in which we note the colour and clarity of the urine and measure the urine-specific gravity, the chemical exam, which we do via the dipstick, and the sediment or microscopic exam. Any elevation of 20 or greater is indicative of impaired GFR and is something you should act on immediately because it means detection of disease or reflection of something affecting the kidneys. And we'll go into more detail about what this means shortly. For elevations of 15 to 19, it indicates a reason to perform additional diagnostics to determine if there is other evidence of kidney disease. We'll talk more in a moment about what this evaluation looks like. In the event that you do find other evidence of kidney disease, again, we recommend you act now. If you don't see any other evidence of kidney disease, then we recommend that you recheck the kidney panel in 2 to 4 weeks' time. We recommend that that panel includes a minimum of SDMA, urea, creatinine, phosphorus, and a complete urinalysis. If that recheck panel still doesn't show kidney disease, then we recommend that patient has a follow-up evaluation in 6 months' time. If when you recheck the panel in 2 weeks' time, SDMA remains persistently elevated, even if we don't think there are other signs of kidney disease present, we recommend that you will follow the IMM protocol with these patients, because that persistent elevation is telling us that that patient's GFR is remaining impaired and we want to act now. With regards to other evidence of kidney disease, it involves us doing things such as considering the patient's USG. Is it inappropriately low? As a rough guide, in dogs, we would say this is a USG of less than 1030, and in cats, we would say this is a USG of less than 1035. If we have active urine sediment present, particularly casts, white blood cells, or bacteria, we would consider this evidence of kidney disease. If our patient has protein urea in an inactive sediment, so that's a UPC ratio of greater than 0.5 in a dog or greater than 0.4 in a cat, we should consider this evidence of kidney disease. If our patient has elevated urea, creatinine, and/or phosphorus, that's fairly convincing evidence of kidney disease. Likewise, we don't want to forget about creatinine trending upwards within the reference interval. This can be considered evidence of early kidney disease. We want to go back to our patient history. Is the owner reporting polyuria, polydipsia, anorexia, and/or weight loss? Go back to our physical exam findings. Did the kidneys feel abnormal on palpation? And certainly, if we can document that the kidneys look abnormal on imaging, or we have a patient that has unexplained persistent hypertension, we should consider that evidence of kidney disease. SDMA is highly correlated to GFR, and therefore any impairment of GFR can cause an increase in SDMA. So what SDMA is telling us is that it's helping us to detect diseases of the kidney sooner and reflect other disease processes that are secondarily affecting the kidneys. So increased SDMA should inspire us to perform clinical investigation for underlying disease. Once you have determined that you need to act now, the next steps are investigate, manage, and monitor. Thus, you may also hear this algorithm referred to as the IMM, so investigate, manage, and monitor protocol. The first step is to look for an underlying cause as well as confounding or complicating conditions such as hypertension or proteinuria that may accelerate kidney disease. In cats, a big one for us to assess is thyroid status. Which additional diagnostics we perform will depend on the patient's history, our physical exam findings, and our clinical judgment. Be sure to go back and question the owner around any possible toxin exposure. So, for example, any possible access to lilies for cats. Also, don't forget to ask about potential exposure to infectious agents that may be risk factors for kidney disease. For example, leptospirosis is associated with acute kidney injury. In cats, we don't want to forget about the retroviruses, so FIV, FELV, as well as feline infectious peritonitis and toxoplasmosis. We would consider abdominal imaging if we were suspicious that the patient could at all have pyelonephritis or stones, for example. The next step is to manage, and there are 3 aspects to this. First is to treat any underlying conditions or those confounding or complicating conditions that have been identified. So we will treat as appropriate based on what has been identified. The second is to provide kidney support immediately. And these are pretty basic things that the owner can do at home, such as providing access to a variety of fresh, clean water sources, potentially discontinuing or limiting the use of nephrotoxic drugs, and making sure the patient is receiving a kidney supportive diet. Thirdly, we need to consider anaesthesia protocols. If the patient is in for an elective procedure, then we want to investigate first, making sure the pet is stable prior to proceeding with anaesthesia. If it is an emergency, then we'll make adjustments to the anaesthetic protocol to make it as safe as possible for our patient. Ultimately, we want to maintain renal perfusion and GFR during anaesthesia, So we want to make sure we have good venous access, consider our anaesthetic protocol, put our patient on IV fluids before, during, and after the anaesthetic, monitor and maintain blood pressure, and ensure that we have adequate oxygenation. Lastly, it is important that we monitor these patients, as patients can move back to an investigation stage from management or monitoring depending on progression or change in renal status. If when we recheck our renal biomarkers, SDMA returns to normal, then that is telling us that our patient's GFR has been restored to normal. This can occur in situations where our patient may have recovered from a mild injury, has responded to appropriate therapy, or there have been compensatory mechanisms at play. We would recommend that these patients have a follow-up recheck in 6 months to 1 year. If when we recheck our patient's renal biomarkers, we find that SDMA is continuing to increase, then this is telling us that the GFR impairment is progressive, and we should consider that this patient has ongoing active kidney injury. So we really want to go back and revisit, investigate, repeat or perform additional diagnostics, and institute ongoing appropriate supportive care. If when we recheck our patient's renal biomarkers, we find that SDMA remains increased but stable, so for example, it was initially 17, we recheck it a couple of weeks later, it's 18, then that's telling us that our patient's GFR is impaired but stable. We likely want to consider a diagnosis of chronic kidney disease here, so we're going to refer to the IRIS staging and treatment guidelines, as well as instituting appropriate supportive care and monitoring. So who is IRIS? Well, IRIS stands for International Renal Interest Society. They are a board of 15 independent veterinarians from 11 different countries that have expertise in nephrology. IRIS was created to advance the scientific understanding of kidney disease in small animals. Its mission is to help practitioners better diagnose, understand, and treat canine and feline renal disease. IDEX SDMA was incorporated into the guidelines back in 2015, acknowledging SDMA as a renal function test to complement serum creatinine in evaluating patients with early chronic kidney disease because it may be a more sensitive biomarker of renal function than fasted serum creatinine concentrations. We all know that earlier diagnosis and treatment may slow the rate of disease progression and thus increase our patients' longevity. Recently, IRIS enhanced the role of IDEX SDMA testing in their 2019 update of the CKD staging guidelines. These guidelines were most recently updated in September of 2019 to present the most current IRIS recommended practices for diagnosing, staging, and treating chronic kidney disease in dogs and cats. Changes made to these guidelines are based off GFR data from a couple of different institutes and are backed up by both published and non-published GFR data. The key point is to remember that increased SDMA does not necessarily mean chronic kidney disease or CKD. We need to make sure we are doing a complete investigation when SDMA is increased so that we don't lose sight of the aspect of SDMA that is not CKD related. IRIS has defined CKD as persistent renal function loss. Therefore, for us to demonstrate persistence, we are going to need more than one set of laboratory results. Why is staging of CKD patients important? It provides insights into life expectancy and treatment options, and as such, helps us to improve the ability to manage our CKD patients. It allows us to begin an individualised treatment and monitoring plan for each patient. Furthermore, it allows us to educate pet owners so that they make the most informed decisions for their pet. Staging helps our conversations with clients once a diagnosis is made. Pet owners will often ask us, is there anything we can do for her? How long does she have? If we are not staging each patient, it is going to be challenging for us to provide the best advice to pet owners. By assisting pet owners to make more informed decisions regarding their pet, we have a greater likelihood of client compliance and thus a greater likelihood of achieving better outcomes for our patients. When we start with the focus of the patient, everything falls into place. Both the pet owner and practice feel confident about the medicine and standard of care we are providing. Chronic kidney disease is diagnosed based on evaluation of all available clinical and diagnostic information in a stable patient. Following diagnosis of CKD, the IRIS board recommends using serum creatinine and SDMA to stage CKD with substaging based on assessment of systolic blood pressure and proteinuria. The IRIS guidelines ask the clinician to take into account both historical and physical exam findings alongside renal biomarker changes in every patient. Physical exam findings are more severe as kidney disease progresses into later IRIS stages. With regards to diagnosing CKD early, so that's specifically referring to IRIS stage 1 and early stage 2 CKD patients, so those that have typically been hard for us to find because they look clinically normal, IRIS have said that we can use one or more of the following diagnostic findings. Firstly, when it comes to creatinine and SDMA trended increases, we're looking for either of these increases or a combination of both. You may notice that the trending of SDMA within the reference interval can now be considered alongside the trending of creatinine within the reference interval. This was a change made in late September 2019. Also note, they have added in a statement about no pre-renal cause being apparent. So again, this serves as a reminder that we need to have eliminated that component that could be related to dehydration. Secondly, we can demonstrate a persistent increase in SDMA. Thirdly, we can demonstrate abnormal kidney imaging. And fourthly, we can demonstrate persistent renal proteinuria. You will note, with the exception of abnormal kidney imaging, there's a real emphasis on the word persistent. So we need to document that this change is repeatable, and thus we're not talking about making this diagnosis of a single set of blood results. To diagnose more advanced CKD, you would see an increase in both biomarkers as well as inappropriate urine-specific gravity. These changes should be found in combination with those that were used to diagnose stage 1 and early stage 2. In the update in late September 2019, the IRIS board added in a statement around the urine-specific gravity of cats, in which they've said, note that some cats can produce hypostenuric urine in the face of renal azotemia. This statement was based on some newer evidence that's starting to emerge, which suggests that cats can likely hold their urine concentrating ability longer than what we thought. So their USG may not match their renal biomarkers, as they can still have urine concentrating ability, but also be facing renal azotemia. The step after diagnosis is staging. And this is where significant changes were made in the 2019 update. Namely, you will now see that SDMA is equally as important in the staging of disease as creatinine. This allows us to use both biomarkers to determine the most appropriate stage of the disease and therefore decide on the best treatment plan. Staging should be based on a stable increase in creatinine and SDMA, meaning that we do not suspect there is any ongoing progressive damage and disease which needs to be investigated. In the case of a staging discrepancy, so that is a patient's creatinine and SDMA concentrations do not put them in the same stage, the IRIS board has two recommendations. Firstly, consider our patient's muscle mass, because if they're skinny, underweight, have poor muscle mass, their creatinine will be low as a result and could be understaging them. Secondly, consider retesting both biomarkers in 2 to 4 weeks. If when we retest them, if both biomarkers are persistently discordant, then we want to follow whichever biomarker is going to put our patient in the higher stage. Remember that every time a dog or cat is staged, the criteria for substaging should be investigated. A blood pressure evaluation should always be completed, and a urine protein creatinine ratio is indicated by the presence of protein in the urine when the sediment was inactive. These substaging are essential to choosing the right treatment plan and medications for dogs and cats with chronic kidney disease. Treatment recommendation continue to be based on stage of CKD. Remember that these recommendations build on each other, meaning that all of stage 1 applies to stage 2 and so on up to stage 4. Minor changes were made in the treatment recommendations in the 2019 update. The order in which the recommendations are listed is the order in which the IRIS board wants us to consider them in terms of importance. Changes that were made in late 2019 were that use nephrotoxic drugs with caution was moved right up to the #1 position. Correct pre-renal and post-renal abnormalities was moved much higher up the list as well. They have added in a statement around monitoring creatinine and SDMA in our patients. This is to ensure that we are either establishing they are stable within that stage, or if they're potentially progressing, do we need to go back to the investigate stage and see whether there now may be something else at play, or do we potentially need to move them up a stage and consider additional treatment recommendations?